disorders, those that are due to coagulation factors, vessel wall problems and all that. So when you look at the first lecture, you'll be able to see the classification of the hemostatic disorders. No, this hemostatic disorder include both the bleeding disorders and the clotting disorders. So thrombotic disorder is one arm of those hemostatic disorders, clotting disorders, and there are various types and causes to it. But we do as much as time permits us. So thrombotic disorder, we say that they are responsible for 1 in deaths worldwide. Can imagine, very significant. A problem, a situation that can cause a mortality rate of 1 in 10 deaths worldwide. It's quite much, rendering it a major public health priority. Thrombosis is the underlying cause of most heart attacks, strokes, and venous thromboembolism. So we are classifying thrombotic disorders as venous thrombosis, arterial thrombosis. Under venous thrombosis, we have deep vein thrombosis. We have pulmonary embolism. Under arterial thrombosis, we have a peripheral arterial thrombosis, cerebral arterial thrombosis, coronary artery thrombosis, sorry. So this is a few classifications. So venous thrombosis, we have deep vein thrombosis and pulmonary embolism. The deep vein thrombosis is when blood clot forms within the deep veins, usually of the legs, but this can occur also in the arms and the mesenteric and cerebral veins. That is, blood clots in the veins, especially the distance veins, like the legs. While pulmonary embolism can occur when those blood clots that has risen in those distal parts of the body, like the legs, when those blood clots moves or are dislodged from one area to another, to the pulmonary vasculature, and obstructing the arteries there. Okay, so we refer to it as pulmonary embolism when those clots that are formed in DVT dislodged and go and obstruct the pulmonary arteries. We call that pulmonary embolism. So what is VTE? Venous thromboembolism is an intercalated condition of deep vein thrombosis and pulmonary embolism. We normally say VTE is equals to DVT plus PE. That is, venous thromboembolism is equals to deep vein thrombosis and pulmonary embolism. The incidence of VTE in Europe and USA is estimated to be 1 in 2 per 1,000 persons, but varies widely by age, sex, race, and medical conditions. So we are giving the statistics of Europe and US, where they have established the incidence of this condition. In Asia, the rate of VTE are thought to be lower than in Europe and in the USA. For instance, the incidence of VTE in South Korea was estimated to be 0.2 per 1,000 person years. Fewer data exist for South America and Oceania. A study from Buenos Aires, Argentina, found a VTE incidence of 0.7 per 1,000 person years, and a study from Perth, Australia, found a VTE instead of 0.8 per 1,000 person years. Very little is known about VTE incidents in our environments. Okay. So VTE, we say this VTE is DVT and PE. So what is deep vein thrombosis? When you look at this diagram here, we say it's normal blood clots that forms majorly on the distant parts of the body, like the leg. You can see this diagram here showing normal blood flow. Normally, blood supposed to flow throughout the veins in the body. But a vein with deep thrombosis, you can find out that there is no free flow of the red cells. The thrombus have already started forming on the veins of the leg. Okay, you can see these thrombus that have dislodged and going up probably to the pulmonary vasculature, where it can obstruct it to form pulmonary embolism. So this diagram depicts, that shows the formation of the clots. Okay, deep vein thrombosis is an obstructive disease with a hindering venous reflux mechanism. Okay, DVT usually involves the lower limb venous system, with clot formation originating in a deep calf vein and propagating proximally. A deep vein thrombosis is a blood clot that forms within the deep veins, usually of the leg, but they can occur in arms and mesenteric and cerebral veins. It is part of the venous thromboembolism disorder, representing the third most common cause of death from cardiovascular disease after heart attack and stroke. Okay, so this is what we call deep vein thrombosis, formation of blood clots in the distal or lower limbs of the body, especially the deep calf veins, the veins of the leg. Yeah, that is why it is advised that sitting down for a very long time is not advisable. You sit down, then you move. Then you also stand up and move so that to initiate your blood to be flowing freely. Okay, also long flights, while you are there, you do some exercise with your feet just to encourage your blood to continue to flow, to avoid stasis. Okay, to avoid stasis and the formation of deep vein thrombosis and pulmonary embolism. So we say that DVT, it is a common VTE disorder. Don't be confused. DVT, VTE. DVT is a common venous thromboembolic disorder that affects approximately 1 to 2 per 1,000 people annually. The rate of particular sites involved depends on the anatomical location as follows. Distal veins are involved in DVT 40%, popliteal 16%, femoral 20%, common femoral 20%, and iliac veins 4%. You can find out that the distal veins are more prone to the formation of DVT. DVT accounts for 1/2 of VTE. Carefully evaluated, up to 80% of patients with VTE have one or more risk factors. Majority of lower extremity DVT arise from calf veins, but 20% begins in proximal veins. About 20% of calf limited DVT will propagate proximally. So these are some of the risk factors that are indicated in the development of DVT. Malignancy like cancers, in malignancy, there's proliferation of cells in the system, and this proliferation of cells can actually result in blood viscosity. That is, the blood becomes sluggish in its movement, slowed down movements, and can actually trigger off blood clotting. Okay, in surgery cases, the patients are sort of immobilized. Okay, trauma. Okay, pregnancy, oral contraceptive or hormonal therapy, immobilization, inherited thrombophilia. Inherited thrombophilia means that some persons have the tendency, because of some genetic mutations they have some tendency of developing clots in their system. That's what we call thrombophilia. Presence of venous catheter, congestive failure, antiphospholipase antibody syndrome, hyperviscosity, nephrotic syndrome, okay, inflammatory bowel disease. Who is this Chioma that is often and on? I will admit her, she will go out again. Okay, so there are some of the risk factors. Clinical presentation of DVT. How does it present clinically? How can somebody be able to suspect, okay, that he or she may probably have developed DVT? There may be calf pain, pain on the leg, tenderness, swelling, redness, and human signs. Overall sensitivity specificity of this is 3 to 9%. Okay, that is 90. Unreliable for diagnostic decisions. Okay, overall, it's not that these clinical signs are specific, but this well-developed diagnostic algorithm clinically to um, be able to characterize the pain someone is having in order to identify whether there's likelihood that it's DVT. So clinicians normally use this well score. They use this well score to characterize the signs and symptoms. To characterize the symptom, the person is having. Okay, the well score is a clinical decision rule used to assess the probability of DVT. It helps determine if further diagnostic testing, like the ultrasound, is needed. So in this well score, okay, the following were assigned a point value of 1 if present. Like if the person is having cancer, we score 1, just like we have in our bleeding score, ISTH bleeding assessment tool. I don't know whether you have come across it. So we use it to score the degree, the severity of the bleeding someone has. So this is another clinical tool that are used to score the clinical presentation of DVT. Okay. So bed rest, more than 3 days, or surgery in the past 4 weeks, they score 1. Localized tenderness, colorectal superficial vein, pitting edema greater than unaffected leg, calf greater than 3 centimeter larger than unaffected leg. Okay, entire leg swollen. Okay, you can see some persons after a flight, you find out that one of their leg is actually swollen. Okay, if there's alternative diagnosis, more likely than DVT, 2 points. Probability high. Okay, if we have a score that is greater than 3, there's probability that the person may have DVT. If it's moderate, between 1 and 2, or low or less. So DVT risk is high, 75%, moderate 17%. That is the percentage of probability of this DVT. Then if the probability is high, that is greater than, the score is greater than 3%, that means DVT risk is high, so up to 75%. If the score is moderate, DVT risk is also moderate, and if the score is low, DVT is also low. So interpreting the well score, low probability means that well score is low, DVT is considered unlikely. Further testing might include a D-dimer test to rule out DVT. Why are they evaluating D-dimer? Why are they evaluating D-dimer? Okay. D-dimer, how when you look at your coagulation pathway, you find out that the D-dimer are products of fibrinolysis during the breakdown of fibrin clots. That is at the end of clotting, when there is resolving of the clots. Okay, we have D-dimer, so they are indicators that clotting has actually taken place and also completed. Okay, so they indicate that clotting is actually going on. High probability, well score greater than 2, DVT is considered likely. Further testing such as lower extremity ultrasound is recommended to be able to visualize, it's a clot that is formed. So when the radiographers carry out their investigation of imaging, they will be able to actually see the clots that have been formed. DVT and D-dimer, like I was explaining, fibrinogen degradation products. That is why when we evaluate D-dimer, we're actually trying to, if we are suspecting a problem of clotting in someone and you evaluate D-dimer, you're actually trying to pin down the fact that coagulation is occurring and it goes into completion, okay, before you can see the fibrinogen degradation product, which D-dimer is part of. If D-dimer test is negative, you exclude VTE. That means there is no complete blood clotting that is forming. Preferred test, quantitative rapid test. Okay, that's for measuring the D-dimer. Either you use the latest method or you use the ELISA method. Okay, so it's still the same thing that we are saying here. In 283 patients with suspected DVT, low, moderate, well scored DVT, and negative D-dimer, only one, okay, had DVT over the next 3 months. So D-dimer is quite sensitive test, can rule out DVT in low, moderate risk patients. D-dimer is sensitive, can rule out DVT. So you can see an image image diagram of DVT. You can see the radiographer will be able to actually visualize and see the clot and confirm that there is blood clots, there is DVT. Available imaging and ancillary tests, compression ultrasound, venography, MRI, impedance plus micrography, okay, complete lower extremity ultrasound, experimental. So you can meet your radiography colleagues, they will explain all these processes better for you, but we can use imaging to also diagnose DVT. So this is a diagnostic algorithm using D-dimer testing and ultrasound imaging in patients with suspected DVT. Is an algorithm. If someone shows signs or symptoms of DVT, low pretest probability, okay, using the well score, moderate or high pretest probability. Okay, if there's low pretest probability, the person is subjected to D-dimer testing. If there is high pretest, ultrasonography. Okay, so you follow all those, because this high or moderate or high pretest probability, there's probability that when imaging is done, they can visualize it. But in low pretest probability, they may use the dimer to either rule it out or rule it in. So ultrasound positive DVT, of course, because you have seen the clot. Ultrasound negative, they are ultrasound negative, they are performing D-dimer. If it is positive, repeat ultrasonography in 1 week to see whether you'll be able to visualize the developed clot. If it is negative, there's no DVT. So same follows here. If it is negative, no DVT. If it is positive, ultrasonography. If ultrasound is negative, of course, no DVT. Positive DVT. So this is an algorithm, okay, they use also to evaluate that. So pulmonary embolism, What is pulmonary embolism? We say that pulmonary embolism is defined as an occlusion in the pulmonary arterial tree by material, for example, thrombus, tumor fats that originate elsewhere in the body. You can see the pulmonary vasculature that the thrombus can occlude or block. Okay. PE epidemiology. Okay, the incidence of PE diagnosis in the United States, and again where we have data, has risen, is on the increase. The reported incidence in 1998 was 62 per 100,000. In 2006, it rose to 112 per 100,000. In 2016, 120, 2019, 393 people were diagnosed with PE. You see the trend where they have accurate data. Okay, a similar temporal increase in the incidence of PE has been reported from various European countries, including Denmark, Spain, and Italy, and from Australia. On the European front, Sonny et al. Published in 2022 and identified patients who are more than 18 years old in Denmark with first-time hospital diagnosis of PE. Okay, the patients that were admitted inside in the hospital, you know, sometimes hospital stay is a risk factor. Okay, risk factor. Hospital stay in the sense that you are immobilized, your mobility movement is restricted, you don't move around. So some patients that were admitted and develop PE for the first time. Okay, their study clearly showed an increasing incidence of PE over time in all age groups. Okay, also 100 to 200,000 deaths per year are due to PE. Okay, and most of the PE arise from lower extremity, from the deep veins of the leg, just like we showed when we are considering DVT. In patients with DVT, 40 to 60, we have a PE. Okay, on a VQ scanning. Okay, again, your colleagues in radiography will explain all this imaging better for you. Pulmonary embolism, as described by Ken Mosier, he said that pulmonary embolism is not a disease, it is a complication of DVT, and you can as well agree with him on that, because it's as a result of dislodging of the clots that are formed, especially in the deep veins of the leg. They dislodge and go to the pulmonary arteries and occlude the pulmonary artery. So PE is a complication of DVT. Clinical presentation of PE. Okay, clinical presentation of PE include dyspnea, pleuritis, pleuritic pain, cough. Most common is the most common symptom. Tachypnea, RELS, tachycardia. Most common signs are also common signs. ABG limited valve for diagnosis. EKG and chest X-ray often abnormal, but usually lacking specificity to aid diagnosis. So the sequence of right ventricular failure in acute pulmonary embolism, pulmonary embolus, right ventricle. Okay, so sort of the flow of the embolus before they finally obstruct the pulmonary artery. Okay, and cause arrhythmias and hypotensive shock. So acute PE causing pulmonary vascular obstruction and constriction. So when this embolus moves from the place where they originate, like the deep cap of the vein, and the bloodstream, you know, the bloodstream will also move it along as it's flowing. Okay, they tend to obstruct the pulmonary vascular, the vasculature. Okay, and this obstruction, will result in also vasoconstriction, narrowing of the blood vessels, and this will result in increased right ventricular afterload. Okay, so it will result in increase in pulmonary arterial pressure, dilatation of the RVO, decrease in stroke volume. So all this dislodging of the embolus and obstructing the pulmonary vasculature will result finally to irregular heartbeat, irregular rates, arrhythmia, and hypotensive shock. So this is some of the diagram where they can show the abnormal arrhythmia, heartbeats. Okay. Okay. Chest X-ray findings. Okay, they will find that wedge-shaped configuration at lung periphery, wedge-shaped configuration at lung periphery due to infarcted lung. Westermark, they call this one Hampton's hump. Westermark sign, pulmonary oligemia. So these are some of the things that this diagram is trying to show us. Marked decrease in vascularity, characteristics of Westermark sign. Okay. Tumor limited superiority by fissure. Okay. So this is how PE can be evaluated in the lab, can be evaluated not in the lab by imaging. Okay. Anticoagulation is same other therapy that you can use in managing VTE. VTE we say is DVT plus PE. We have said that VTE is DVT plus PE. So apart from the some other ways they can use to manage it include anticoagulation. Anticoagulation is same both for DVT and PE. Thrombolysis, okay. The risk, the benefit is not certain. Clinical outcome generally not improved. Vena cava filters, they can also use vena cava filters, but it's contraindication to anticoagulation. Rarely survivors of massive PE, okay. Rare patients with recurrent VTE or inadequate anticoagulation. Prophylaxis is certain high risk. Prophylaxis in patients that have high risk of developing VTE is best to give them prophylaxis. Probably that what that means is that maybe a patient is on cancer treatment. Okay. Number one, you know that cancer, being a myeloproliferative disorder, results in increase in production of blood cells. And this increase in production of blood cells, will add to viscosity, the blood being more viscous, and that alone will slow down the movement, the free movement of the blood in the vessels, giving rise to developing thrombosis. That is one. On the other hand, some of these patients that are cancer patients or myeloproliferative patients, their movement, also physical movement, is slowed down. So coupled with the fact that the blood flow in their system is slowed down, their physical activity is also slowed down. So in managing them for their disorder, it is advisable to also give them treatment, therapy that can help their blood not to clot. You don't have to wait for their blood to clot. That is the prophylaxis. You take care, you put into account that these persons have a tendency of developing this. So let's do this to prevent it as much as we can so that it will not occur. So, but prevention, sometimes they say that the prevention of VTE is underutilized. Okay. This is again for countries that have data. only 32% of medical patients with DVT receive DVT prophylaxis. So sometimes it's just that is why we are creating awareness. This World Thrombosis Day we do. We are creating awareness for it. I don't know how people will join so that we can do. It's normally those of you that will be around in Enugu, October 13th. Maybe after your exam, we do discuss how we will do that. We gather to create awareness. And also, they are creating this awareness. If you are admitted in the hospital, it is your right to ask the clinicians, what is my thrombosis risk to VTE risk? Okay? Because as they are treating you, you are there, you may be developing another deadly disorder. Okay, so we are creating awareness during World Thrombosis Day to tell people that sit a lot in their offices. You sit, you get up, you move around. You do a long distance travel. There's a way we do ankle exercise even in your flight. Okay, so that is the awareness the World Thrombosis Day is trying to create. Okay, and also coming to the consciousness of the clinicians to also manage their patients, considering the fact that while they are treating this patient for this condition, the patient may be developing little symptoms, may develop little risk factors in their system. So that should be taken into account. For our locality, we don't even have data on prevalence of VTE and DVT, not to talk of whether it's prophylaxis is underutilized or not. Okay, prophylaxis in medical patients. Indications for prophylaxis, that is prophylaxis even in medical patients that have congestive heart failure or severe respiratory disease. There is need for them to be scored, their VTE risk scored, and they will place on prophylaxis. Bed rest with additional risk factor like cancer, those with cancer, prior VTE, acute neurologic diseases, inflammatory bowel diseases, most patients in the ICU, okay? The options that are available here, the clinicians will know more. Low dose unfractionated heparin or low molecular weight heparin, sequential compressions devices, graduated compression stockings. Okay? These are things that can help add as prophylaxis in these patients that have the risk of developing VTE, even while they are being managed for their another condition in the hospital. So DVT and PE are the same disease. You can see the pathophysiology, how it develops. Okay. Assigning pretest probability for VTE is an essential step in diagnosis. Okay. DVT and PE can be diagnosed or excluded in many but not all patients using non-invasive means. VTE can be safely managed with heparin for at least 5 days and simultaneous warfarin without a loading dose. Always consider VTE prophylaxis in inpatients. Thank you. Thank you. So we may not be able to go more than this because of time.